Hello, everyone. Welcome to the PAPERI webinar series. I'm Dr. Wafa Rashid, Chair and Founder of Pan-African BGS Education and Research Initiative, PAPERI. I will be your today's moderator. Thank you for joining us for our session today. I'm delighted to introduce our esteemed speakers, Professor Benard Mwori Sorre and Professor Constance Tenji. Professor Benard is a medical anthropologist at the Mwori University School of Arts and Social Sciences, Department of Sociology, Psychology, and Anthropology. He is currently a collaborating investigator in a project titled Sickle Cell Disease Registries and Control Program SCD-RCP, whose objective is to strengthen evidence-based management of SCD in a control program by setting up registries, screening services, and strengthening the specialized clinics. Through the project, they have continued to provide community, patient, and clinical support to several sickle cell disease hotspot counties in Kenya since the year 2019. Professor Sorre is a member of the research committee focusing on non-medical research at the Sickle Cell Federation of Kenya, an umbrella organization that brings together patient organizations, caregivers, clinicians, and partners to improve the lives and long-term prospects of people affected by sickle cell disease and related blood disorders. Also, Professor Constantine is a pediatrician and professor of pediatrics at the Mwori University College of Health Sciences, School of Medicine, Department of Child Health and Pediatrics. She is principal investigator of a project titled Sickle Cell Disease Registries and Control Program, SCD-RCP, whose objective is strengthening evidence-based management of SCD in a control program by setting up registries, screening services, and strengthening the specialized clinics. Professor Constance, together with her team, did a survey in counties in Western Kenya and generated a technical report that was published on 27 October 2025 in the Journal of Community Medicine and Public Health Reports, Volume 6, Issue 8. This report provides the framework that's useful guide for the implementation of the World Health Organization interventional strategies, primary, secondary, and tertiary, required for the achievement of a successful SCD control program. Professor Constance is a member of the Technical Working Group on Hematological Conditions at the Ministry of Health. Also, Professor Constance serves as a chair scientific committee of the Sickle Cell Federation of Kenya, whose role is to take care of the welfare of BLW-SCD and to set the required standards of care, education, and research. In today's session, Professor Benard will talk about proximate determinants of health among BLW-SCD, while Professor Constant will talk about implementing a sickle cell disease control program, rule of data, and registries. Please join me in welcoming Professor Benard and Professor Constant. Please note that we will have a live question and answer session at the end of the webinar. You can write your question in the chat to submit your question. Please mute your microphone. Professor Benard and Professor Constant, the floor is yours.
Thank you so much. Thank you so much, Dr. Rashid, for the warm welcome. I know I have around 20 minutes to make my presentation. Then Professor Tenge will remain with the remaining part of the presentation. So I hope you can see my screen.
Yes.
Can you see my screen?
Yes, I can see your screen. Please start.
Thank you. I want to share briefly about proximate determinants of health among persons living with sickle cell disease. The real reason why I want to share this is because It is something that is coming from the community, from the people themselves. It is out of their own lived experiences. They raise issues that we who are talking about sickle cell disease need to focus on as we help them go through their life situations. We all know that sickle cell disease is a genetic condition that affects the red blood cell, and that may not want to go into details, but very important.
I'm going to mention that. But what you could do while you're explaining the different ensemble data types is to just kind of give an overview of what tools people can find.
I did not get you. Can I proceed?
Yes, please.
Yes, I say that sickle cell disease is a genetic condition that affects the red blood cell. And I said I will not go into the details of that because Professor Teng will speak about the clinical aspects. But the very important thing for us here is that this is a condition that is lifelong. One is born with it and has to live with it the rest of his or her life. Now, when we talk about their health, we compare it with what World Health Organization says, that health is a state of complete physical, mental, and social well-being, and not just the mere absence of disease or infirmity. According to me, people living with sickle cell disease have a lot of health challenges, and I define their health in various perspectives. One of them is the physical aspect of health. That is proper nutrition, regular movements, and quality sleep. These people also have mental and emotional issues. They always have to manage their stress. They are always cultivating emotional conditions, so they need resilient. And also, we need to foster their self-awareness. We are also talking about health by looking at how socially these people are supported in terms of building relationships, connections with their communities and the people around them, and giving them a sense of belonging. Spiritually, these are just like any other human beings with beliefs, and therefore they need to be given meaning, purpose, and a reason to continue living just like any other person in the community despite their health condition. And that's why their inner peace is very important. In terms of environment, health for persons living with sickle cell disease requires that they have a safer and healthy environment that supports their daily life experiences. With that kind of broader understanding of their health conditions, it is important to understand what are the proximate determinants. These are immediate or direct factors that directly have impact or implications on their health. Any of these aspects of health I've mentioned, whether they are social, economic, biological, or environmental, or any other that affects the health of this patient or their disease outcomes. Therefore, proximate determinants are those factors that contextualize lived experiences of persons living with sickle cell disease. This presentation is an extract from a study that we did on 5 counties in Western Kenya, and we were able to study 76 health facilities, and we engaged 2,056 persons living with sickle cell disease. And our main objective was to strengthen evidence-based management of sickle cell disease in a controlled program by setting up registries, screening services, and strengthening the specialized clinics. However, during that interaction, there were several objectives that we were looking at, and this particular presentation, I extracted evidence from the third objective, which was to come up with registration of persons living with sickle cell disease. So we were able to capture their lived experiences by looking at their demographic characteristics like gender, the occupation, where they lived. We are also able to capture the environment, the family, the socioeconomic status. We were also able.
We are not
Yes.
able to see your slides. It's just the first slide that you have highlighted. Is it possible to follow the slides?
Yes, I am sharing. I'm moving with it. I don't know why it is not. Okay.
Yeah.
Are you able?
Unshare and then reshare.
Prof,
Are you
unshare,
able to
then share again.
Okay,
And
okay. Let me
share.
just. Sorry for that. Sorry for that. Are you able to see it?
Yes.
Yes. Yes, it's now okay. Now
Yeah, I was just saying we were able to, this was a product of a study that we did, and the data we are using as evidence for this current presentation is from the third objective of our study, and I just picked a section of it where we were able to interrogate persons living with sickle cell disease, and we collected data on various aspects of lived experiences they were sharing with us. The demographic, the family status, socioeconomic conditions, the genetic history, the possession of medical insurance cover, the kind of mode of payment they were using or doing when they would go to hospital, whether they had had some diagnosis or not, whether these patients had had experience with hospital admissions, blood transfusions, ability to access and afford medication required, and so on. So based on this, we are able to identify the following proximate determinants. Are you able to see the next slide?
Not yet. We are on slide
I-
number 6.
No, we can't.
I don't know why it's not moving.
No problem. I will share mine so you can please tell me next.
Yes, just go to first proximate determinants. I can unshare.
Can you see my screen?
Let me unshare mine first. Sorry for that.
No need, no need.
Yes,
I just shared mine. Can you see my screen?
Yes, yes, I
Okay.
can see yours now.
Yes. So please continue.
Thank you. Yes, I was saying that we were able to identify various social and cultural factors that affect the health of persons living with sickle cell disease. And what we realized was that psychosocial support was very critical for the health of a person living with sickle cell disease. These people, if those who had family cohesion that was good, they had positive coping strategies, they had reduced stress incidences, they correlated well with their ability to self-manage their conditions, and they had very low or few incidences of healthcare utilization or visits to hospitals. And also situations where we had stigma or discrimination that was reported, especially self-reported stigma and perceived discrimination, was highly linked to longer and higher pain severity among the patients, longer hospital stay, as well as increased ER visits. And also in terms of nutrition, because nutrition is a very critical cultural characteristic of a community, those who came from a situation where they experienced undernutrition, including deficiencies in vitamins like D, B12, and zinc, had increased cases of severity, pain, and hospitalization. Specifically, out of the 2,056 patients that we studied, 84% happened to have been under 18. They were children. And most of them, when we talked to their next of kin and even themselves, they mentioned that there were a lot of cultural and social misconceptions about the disease, especially people telling them that the disease is caused by, for example, demons. Those families that had those diseases, something was sucking their blood and there was a problem with one of their family parents. And that's why whenever they go to hospital, they had to be given more blood. So there was those negative perceptions. Others said that these children cannot live beyond 18 years. And for those who were able to live up to 20 and above, they were saying you can't live beyond 25 years. And others were even telling us they are not allowed to marry or they cannot live the normal life. So there were a lot of misconceptions. And stigma came in form of the way people verbalized. They talked about being a bad omen, being beliefs about negative beliefs about the cause of the disease. And therefore, the implications of all these cultural and social factors was that discrimination led to exclusion and therefore poor indicators for persons that were living with sickle cell disease that we encountered. The next slide. Economic factors. We realized that throughout our study, the income and poverty level of the family, the community, or the area where those persons living from with sickle cell disease came from was very important indicator of their well-being. And we realized that because majority were children, we were under 18. When we asked them about their occupation, they said they were children or students. And for those who were above 18, some had even trained up to college level, and most of them were still unemployed. In a recent national conference in Nairobi, this element of unemployment again came up because we had senior warriors who are above 30 years and so in Nairobi. And their main complaint was that the employees were stigmatizing them as not being unusual people. And therefore, this is something that created a gap. Even those that have gone to school, they have passed well, they were not able to be employed in a normal workforce. And that also affected their self-esteem and their health and stress levels. So 34%, for example, had medical cover that was active and also beneficial, meaning you could go with whatever you have as a cover and you're treated and you get the drugs. However, we realized that this was not the real, was not under a normal situation. Out of this 34, around 82% had a medical cover because they were forced to get one since they had had severe and several incidences of admissions. It is cheaper when you are admitted with a cover. That is what forced them. But under normal situation, about 15% had the cover on their own. So income and poverty level are very critical, fertile ground for access to better health for patients living with sickle cell disease. We realized that those from low income, those that had food insecurity, those that had poor housing, for example, ventilations, look at their houses where they sleep, had higher incidences of acute care encounters. Now, the implication of this is that economic factors affected their access to basic care, nutrition, and quality of life. Next slide, please. Thank you. Environmental, which is physical and behavioral space. We were able to identify two aspects of the environment. The physical space, conditions like extreme temperature, whenever it is very hot, you may discover that most of these patients undergo dehydration which is not good because lack of fluids will increase blood viscosity and create crisis. And extreme temperatures like during cold season, when it is raining in Kenya, or when you are in a room and there's AC, for example, in hot areas like in coastal region of Kenya, which is another hotspot area, most of the houses have AC or the fan. That also creates challenges to the health of these patients. Access to specialized care is also an aspect of the environment, and this is now the behavioral or social environment within the community, the estate, or the area where these patients are coming from. What is their proximity to care services, to health facilities? This also affects the preventive therapies, adherence to such cases like, do you go to hospital when you are sick? Can you access transfusion, for example? Can you access vaccines or so? Most of these patients, for example, come from villages, rural areas. Whenever they have attacks, it happens largely in the evening. Transportation is a major issue. So there's that physical space and there's that habit. Do we go or not go? So health literacy was also another issue, which is a behavioral space. There are communities or areas where there's a lot of communication about disease-specific knowledge to people who are involved in those health conditions. But we found out that this was a major gap, especially when we started our project in 2019, 2020. We even tested this with the people who are working as health workers. We gave them a pre-test. Most of them scored out of 10, 4.5 to 5. Then we gave them a CME, and then after the CME, we gave a post-test. After post-test, most of them now are scoring between 8 and 9, which was a very high level of learning. So that was just an evidence that level of knowledge was also still low. So environmental factors affect resilience generally, susceptibility to infections, health-seeking behavior, and quality of life for persons living sickle cell disease. Next, please. Thank you. We also realized that individually, persons living with sickle cell disease had their own genetic and biological variations. There are those their fetal hemoglobin levels were very high, and those cases experienced very few cases of admissions because they had mild levels of attacks. But those with low fetal hemoglobin had more cases of attacks. And that's why we always were asking them, are you able to access to hydroxyurea or not? And majority of them, from the economic condition and the environmental condition, were able to access to hospitals, yes, but they were not able to get some of these drugs, especially hydroxyurea. And where it was available at that time, most of them were not available at an affordable price. Co-inheritance was also another biological condition that was common, although not of our concern, but people with thalassemia, this also lowered the mean cell hemoglobin concentration, which was also advantageous for those who are having that condition. Genotype types, those people, when we are looking at their hemoglobin level and type, we discovered that HBSS, which is generally the sickler, these were more severe cases which had common attacks and so on. But other forms that were like carriers, they lived almost normal life, yet they were the most dangerous. So each of this group was exposed to its own level of danger with regard to their health. The next, please. Thank you. In conclusion, what I wanted to share is that these proximate determinants of their health are not understood. And that's something that we need to understand. Most of these people, from where they come from, their next of kin, their significant others, the people who take care of them, don't understand the role of each of these proximate factors and how they contribute to the health. In most of the occasions, the assumption has been that when you go to hospital, you'll get medication, and you'll be well. But when you come back home, the house you are living in, the peace that you have, the kind of food that you are eating will also contribute to your well-being. However, if information is availed and the situation is known, it will go a long way in reducing pain. The number of admissions among these patients will reduce because they'll have healthier living conditions, and will generally enhance the well-being of persons living with sickle cell disease. Thank you. Thank you so much.
Please unmute.
Dr. Wafa, please unmute yourself. You are not hearing.
Yes, Professor Bernard, thank you so much for your informative presentation. Thank you so much. Do you want to take questions now or at the end of the session after Professor Constance's presentation? What do you prefer?
I think it's better at the end of my presentation so that we can tackle the questions together.
Yes, I agree with you.
Because some of the questions may be overlapping.
Yes, I agree.
Thank you.
Now, Professor Constance, please share your screen.
Can you see my screen?
Yes. Yes, wonderful. Thank you. If you need any help, please let me know.
Okay. Have you seen my next slide?
Yes.
Yes.
Key points to address. Yes.
Yeah, so thank you very much for this opportunity to give a presentation on sickle cell disease control programs, the role of data and registries. I'm Professor Constance Tenge, as introduced earlier. Basically, these are the key points I'm going to talk about. Genetic disorder that can be controlled, and then the World Health Organization interventional strategies, the importance of data and registries, and what areas to strengthen, and what do we require. Most of what I'll talk about is building up from what Professor Sorre had said, because we work closely together. Him as an anthropologist or social scientist, and me as a pediatrician or a caregiver. Both of us are researchers. So we look at the historical background about sickle cell disease. We have known it for more than 100 years, with the first patient being Walter Clement, a 20-year-old dental student. And then the first publication on sickle cell disease was in 1910. It got its name in 1922. And then its relationship with reduced or low oxygen demonstrated, on and on, the issue of fetal hemoglobin and the protective effect of it. And finally, 1956, whereby they showed that the substitution of the amino acid in the beta globin chain. So when you look at the epidemiology of sickle cell disease, this is information, the prevalence, global prevalence of 2021, and we realize that sub-Saharan Africa accounts for 75 to 85% of the cases, and they still increase, and many children are being born with sickle cell disease. We know about the carriers, more than 300 million carriers, or those with the sickle cell trait in the world. And Equatorial Africa is where most of the carriers are. Out of every 10 patients, you get up to 4 persons, not patients. Now, when we look at Africa, we don't know what the actual numbers are. We don't know. I don't know. And which countries have sickle cell control programs. There's a few countries in Africa, and yet Africa carries the burden. I was trying to check out, it's less than 10 countries, and most of them don't have very elaborate sickle cell disease control programs. Now, for us in Kenya, actually, we are yet to know the numbers, and we know that the burden is highest in about 17 to 22 counties in Western, Nyanza, Coast, provinces or regions. So when we look at management, the first successful bone marrow transplant in a child was done in 1984. Then in 1995, hydroxyurea was known to be one of the drugs, or was discovered to be one of the drugs that can change the course of the disease. There is approval, and then in 2000, there is beginning of genetic association studies for sickle cell anemia, and in 2016, other therapies like the monoclonal antibodies are being studied. So we see a lot is going on. Now, when we look at sickle cell disease as a genetic disorder critically, we know about the inheritance, is autosomal recessive. And autosomal recessive is something we need to capitalize on, whereby if this offspring receives the gene from both parents, they'll express the symptoms. Those are the ones who suffer lifelong symptoms. But if this offspring receives just the gene from one parent, they become carriers. And when we look at the hemoglobin variants, about 1,200 types have been described, but most of them have no clinical significance. But for purposes of understanding sickle cell disease and looking for ways of controlling it, we can talk about 3, whereby if a test is done and somebody is told has HBAA, that is normal. If this person received the gene from both one parent, is told to have HBAS, has the sickle cell trait or is a carrier, and you find that generally these carriers lead normal lives. Most of them are not aware they carry the gene and have the potential to transmit the gene to their offspring. Those are the people who are around, are not aware, and perpetuate the gene. And when they get children, they get shocked to get offspring that have sickle cell disease, and looks like these carriers are the ones we need to tackle. No, so that they know their sickle cell status. And then there's this other group whereby the offspring receive the gene from both parents. Those are the ones we call people living with sickle cell disease, or the warriors, or they have sickle cell anemia. And these are the ones who suffer lifelong symptoms. And when you look at it, these symptoms are around anemia, the occlusion, organ damage, infections, and they do transmit the gene to their offspring. So the table on your right shows percentage chance per pregnancy for an offspring, or the type of hemoglobin variant the offspring can get. So you can see parents and then the offspring. And when you look at the 3 lower rows, no columns, rows, those are the ones, or both parents carry the gene and have the potential to transmit the gene and get this patient or persons living with sickle cell disease, or the warriors who suffer all throughout their life. It's not easy for somebody to suffer throughout their lives. So when it comes to management of sickle cell disease, we have the WHO guidelines, which were given to us in 2006. From 2006 to now is like 30 years. It's like 30 years, and some of us keep wondering what is going on with us, because 30 years we have these interventional strategies, and still Africa, which carries the burden of the disease, do not have control programs, and it means we need to do something. So there's the primary, secondary, tertiary interventional strategies. Tertiary is where we manage those people already born and living with sickle cell disease as they present with complications, which are acute and chronic, and around anemia, vaso-occlusion, organ damage, infections. Whatever you do to them is considered tertiary interventional strategies. From giving IV fluids, painkillers, hydroxyurea, bone marrow transplant, gene therapy, that is a tertiary interventional strategy. And in discussions, people keep dwelling on that. Then there's the secondary interventional strategy, where we do newborn screening and start care early, and therefore prevent or delay the complications. And at the moment, there are a lot of activity on newborn screening, identifying those who have sickle cell disease, and this targets families already staying together. Now the question is, if a child has or is discovered to have sickle cell disease, supposed to be linked to care. Which care? Most of the places or most of the countries don't have appropriate care, just like what was highlighted by Professor Sorre. Then there's the primary interventional strategy, whereby we would like to prevent birth of sicklers. And this is where we really need to emphasize activities on. And what is required is just public health education. We tell people this is a hereditary or genetic blood disorder. Inheritance is autosomal recessive. Perpetuation of the sickle cell gene can be controlled. Perpetuation of the sickle cell gene can be controlled. Test and know your sickle cell status. So if you tell people to test and know their sickle cell status, where do they test if things are not in place? And that's what we are trying to struggle with, and therefore make informed choices about their lives, spouse, and offspring. And now, when all these interventional strategies are carried out concurrently, whereby those who are born with sickle cell disease get appropriate care, families staying together, their newborns are screened and linked to care, and those who don't know their sickle cell status when they are still young are tested and guided on making informed choices, it becomes a sickle cell disease control program. And a program is just an organized way of doing things, which is possible. So when it comes to management of the complications, the tertiary interventional strategy, what do we require? We require staff, and nobody should talk about lack of staff, because we are there and we keep training. And there are so many young people who are skilled, are trained, skilled, but with no jobs. That's what most of the African countries are struggling with. And even some countries want to export the skilled staff on this brain drain. So we require laboratory equipment and supplies for diagnosis and monitoring. Then the drugs, those drugs, blood and blood products, IV fluids, whatever it is. So that's what we require for tertiary interventional strategy. For secondary interventional strategy, where we would like to do newborn screening, follow up and provide prophylactic management, we still require the same staff, the laboratory equipment for diagnosis, screening, diagnosis, and monitoring, vaccines, drugs, especially pediatric formulations. You'll find that in most countries in Africa, the pediatric formulations, especially hydroxyurea, are not yet available. And yet, majority of the patients with sickle cell disease are children. So we require formulations for children, blood products, fluids, and all the others. So for the primary interventional strategy, preventing birth of sicklers is just public health education. And that is the message. I've already gone. Perpetuation of the sickle cell gene can be controlled. And we don't require much really staff, health education material, lab equipment, and supplies. Test and know your sickle cell status. So there's this project which Professor Sorre had highlighted, which we carried out a survey in 5 counties of Western Kenya, and those were the objectives. Assess level of knowledge about sickle cell disease among healthcare providers, evaluate the existing healthcare services, register persons living with sickle cell disease, determine the hemoglobin variants. So the 4th one we never managed to tackle. We did the first 3, and that is the summary of the findings. Significant knowledge gaps on sickle cell disease among healthcare providers exist. Health facilities have good infrastructure. We went to the 76 facilities, good infrastructure, good buildings. Guess what? They all had medical insurance, the accreditation, had staff, but those facilities were not able to effectively provide the required basic services for persons living with sickle cell disease. Majority of the persons were aged less than 18 years, and only a third, about 34, had active and beneficial medical insurance, and only a few, 30.8%, could access and afford medications, especially hydroxyurea, required by persons living with sickle cell disease. So these were the recommendations and call to actions. Those were areas of what to strengthen. One of the recommendations was to encourage the government, that is the Ministry of Health and county governments, to take up leadership in the provision of services. Then enhance level of knowledge on sickle cell disease through CME, IEC materials, and other fora. Purchase, stock, and install the medications, reagents, equipment, and the rest. Encourage families to enroll and have medical insurance, and then set up specialized clinics for sickle cell disease and collect standardized information. And this information can be analyzed and used for intervention, and that was a very, very important area. And we actually went ahead to design what was required, and then to set up registries for persons living with sickle cell disease, hemoglobin variants, sickle cell disease organizations. We realized there are so many organizations dealing with sickle cell disease, but one is not able to know exactly what they are doing, because you go on the ground, these patients are suffering. And then what are these organizations doing? And Sickle Cell Federation membership, where the funds can be utilized. So with the work we did, we managed to write a technical report and had it published in the Journal of Community Medicine and Public Health Reports, Volume 6, Issue 8. Then we also set up websites and are working on an online registration application system. Those are the website links. Those are the links, but this is there. So when we look at data, what is data? Data is a collection of facts, numbers, or other information that can be used to make decisions reference and analysis. And what is information? Is the data that has been processed, organized, and interpreted in a context and meaning or value, allowing for informed decision making. So we need to know that there is a lot of data on sickle cell disease that requires to be processed to get information that can guide changes in policy. So what we just require to do is to get it and organize it. And that's what we are working on. So what data do we require for the tertiary interventional strategy? You find that tertiary interventional strategy is targeting the persons living with sickle cell disease. These warriors or these people have a lifelong illness. It never goes away. And they require treatment and long-term care. So the first thing we need to do is to determine the frequency of the disease, prevalence and incidence. How many are they? Where are they? And that's what we are struggling with. We also need to observe the cause of the disease, follow up this patient. The patients are different. You'll find some get frequent attacks and need frequent anemia, transfusions. Others are different. So we need to observe the cause of the disease and we need to measure the quality of care, availability, accessibility, affordability, acceptability. In our survey, we found that quite a number of patients were not able to access care properly and even afford it. Then we want to check whether there is adherence to guidelines and the treatment outcomes. So we designed the data tools, which we call encounter forms. There's the initial encounter form, which can serve as a registry, and then the return encounter form, which can assist to observe disease course and measure quality of care. And then after every clinic attendance, there are summaries which can provide guidance on areas for intervention, to intervene. So this is a sample of the initial encounter form and is for a county called Taita Taveta. What we did was, since we would like the government or the county governments or the Ministry of Health, what we will do as the Sickle Cell Federation was to affix the logo of the Sickle Cell Federation of Kenya and that one of the county. And this can work very well and pick information, demographic information, family information, comorbidities. Currently, there's a lot of attention given to the community health promoters or workers. We ask whether the family identifies with any, while the physical examination, the investigations and the rest, and the diagnosis. So basically, if you look on your right, there's the initial encounter form, which picks demographics, family information, comorbidities, physical findings, investigations, admissions, transfusions, vaccinations, and medications. Then there's the return encounter form, which now picks the name, status of medical cover, whether it's active or not, in the current informations about medications, adherence to medications, admissions, blood transfusion, prescriptions, referrals, and then there's the summary sheet. Every after the clinic, the healthcare providers can do a summary. How many clients did you see? How many were new? How many were visits? And we would like them actually to use the information. The healthcare providers, like the health information records officer, to look for a way of actually identifying or giving the patients their unique identification numbers. And then we ask, does the patient have a medical cover? Yes, no. If no, then intervention should be done. We tell them to get hold of the client and take to what we call champions, the SHA champions, who our governments have employed to do that. And then we ask, is there hydroxyurea available in the facility? Yes, no. If it's not there, mechanisms are put in place to see what is going on. Why is the hydroxyurea not there? We've tried it out and in a few pilot facilities, and it works quite well. Then what data do we require for the secondary interventional strategy where we want to screen newborns and diagnose them early? So we talked about the different hemoglobin variants, whereby if somebody's AS, do genetic counseling, give results, and catch up with them during adolescence. That's what our infant screening policy says. And we know that adolescents can be able to understand information. They have, they can change relationships, unstable relationships, and that's why that can be done. And if a person or a child or the problem is linked to care where, then the data tools are the hemoglobin variant forms, which will be filled by all that have been screened, and then linkage to care and counter forms, and then the summary sheet. So, and then there's the primary interventional strategy, where we would like to prevent birth of sicklers, public health education, and then determination of the hemoglobin variants. The data tools are the same, hemoglobin variant form, which will be taken to the registry office or forwarded. Client's copy. The client should go home with the report, look at it, and move around to see, to understand what is AS, SS, or others. So there's tendency for clients to go asking around, which is just a normal behavior. And then there's the hemoglobin variant summary sheet, which can remain with the facility, the county, the Ministry of Health, or sponsor. And this should be filled by all persons screened and see what actions can be taken, genetic counseling or linkage to care. So basically, this is a hemoglobin variant form, and then the client's copy and the summary sheet. So we see the hemoglobin variant form picks demographics, family information, whether there is medical cover, and if it's not there, intervention, family history of sickle cell disease. We started off our online registry, and we are seeing clients having up to, or persons living with sickle cell having several members or relatives with sickle cell disease. Very interesting. The test type and results. Then the client's copy gives that information, and then the summary sheet, which is highlighted, that can be shared with the relevant organizations. So there are those other registries, organizations that deal with sickle cell disease. There are so many. And then there's the form on the website. So we are asking ourselves, which is this organization? Where is it located? What is it doing? Who is the conduct? So that is the information we are picking. Category, location, type of activities, the conduct person. And basically is just to avoid duplication of activities, and then we can be able to assign roles and responsibilities. We are finding that there's an organization on the far end of the country having members at the other far end, and there are so many things going on. So if we can organize and see what can be done, it will be better and cheaper. Then there's the SFK membership form, whereby we would like people to be SFK members and pay so that we can be able to support the warriors. The warriors or persons living with sickle cell disease are considered to be bona fide. They don't pay anything. They need to be assisted. Others pay Kenya shillings 1,000, which is equivalent to how many dollars? $10, huh? And yearly subscription. As we saw, patients are not able to access care. 30.8 only are able, 70% are not able to access and afford. So those funds can be used. Those are local funds. And then 65 are not able, 66 are not able, or do not have a medical cover. So that's what we are saying. So we urge people to, especially Kenyans, to register. So that is a form for organizations, the name, registration, category, location of activities, representation, types of activities, and then the contact person, then the names of the people they represent. This is SFK membership forms. There's one for caretaker, one for healthcare provider, other members, and persons living with sickle cell disease. So if we look at specialized clinics, we made a recommendation of specialized clinics. Our country is divided into counties, and each county should have at least 5 specialized clinics, and one should look at a distance. What is a specialized clinic? It's a health service that focuses on a specific area of medicine, that is sickle cell disease, or a group of patients with a specific condition, in our case, sickle cell disease. Services include screening, diagnosis, treatment, monitoring, and when we look at registries, we know that there is an organized system for collection, storage, retrieval, analysis, and dissemination of information on individual persons who have a particular disease condition. Or it can be a file of documents containing uniform information, in this case, standardized information about individual persons collected in a systematic and comprehensive way in order to serve a predetermined purpose. And we would like to get those registries. So there are those different types: reporting type, location, and then the form. So we have been mainly paper-based, but we are turning into electronic with online application systems, and we hope that we shall be able to do it, and it can be of value. So we know that the value of patient registries is different. Different stakeholders perceive and benefit in different ways. We have from government, non-governmental organizations, we have politicians, policy makers, they'll pick something. The healthcare providers, professional organizations, patient and patient advocacy organizations, sponsor, payer, they have different values and would like different information, and we hope we shall be able to satisfy that with whatever information we are picking. So in summary, those are the registries: Sickle Cell Disease Organization, Registry for Persons Living with Sickle Cell Disease, Registry for Hemoglobin Variant, SFK membership. We've also designed a form for report of activities periodically and those different activities. And then the summary sheets serve as a backup. And what we were doing is to combine both hard copies and soft copies that eventually deliver a digital registry. We have ethical approvals, and everything we do is within the ethical standards and utilize what is available. And we are able to do a few things here and there, and we would like to move on as a team. Together, each one achieves more. Work is required, and there's a lot of work to be done. So when it comes to what is supposed to be done as we gather this or strengthen evidence-based management, we have our academic mission, which is around education, care, research, and even SFK requires to state the required standards. We would like to do education, train healthcare workers on prevention, diagnosis, and management, which is something ongoing, but you'll always find more and more healthcare workers and want to continue doing. Then we would also want to do public education on sickle cell disease, awareness of genetic risks and carrier detection before marriage or pregnancy. Then there's care. We would like to have regional working group experts to coordinate activities. And we are the ones actually in our country, we seem to be the experts to coordinate the activities, develop guidelines and work closely with primary care providers. And we are working on a healthcare system that can or should provide the basics. So and then carrier detection screening program. So testing is going on. A lot is being put in place for testing. Our problem is linkage to which care. So that care is something we need to do. Then the research, surveillance. And we would like to get the vital statistic reporting system to guide changes in health policy and then plan and evaluate appropriate intervention. So there's need for African sickle cell disease national control programs. This was recommended by a WHO regional office for Africa, I think sometime in 2016 or something of that nature, whereby the countries should have sickle cell disease control programs by the year 2020. This is long overdue, but it's never too late. We are working on it and aiming at 2030. We hope in Kenya and several other countries, there will be those sickle cell disease control programs where they'll be implementing primary, secondary, and tertiary interventional strategies. And this program should provide a comprehensive approach to prevention and management of sickle cell disease. And for a program, it should use simple, affordable, and accessible technology that is feasible so as to benefit a large proportion of the community. A healthcare system that should be able to provide basic requirements, and then education and research activities to provide evidence-based practice and fill the knowledge gap. So that's what we are trying to do. We are encouraging and being available to guide the process. So we call upon the stakeholders and we keep asking who is a stakeholder. For you to have interest in sickle cell disease, it means you're a stakeholder. So it's you and I. Those are patients and clients, families, communities, healthcare providers, companies that manufacture, distribute equipment, drugs, supply, the administrations, governments, international community, and communication channels. And this is teamwork approach where together each one achieves more. There's so much to be done. So we keep asking ourselves, is it possible to have sickle cell disease registries? Know the prevalence and incidence of sickle cell disease, have sickle cell disease control programs? Yes, it's actually feasible. We've tried it out as pilot and worked out with whatever we have, and it's feasible. We see it's feasible. And what role can you play? We require intellectual support. Some of us have very nice ideas. Technical support, we are there. Material support, that's where problems are. Funds, find those who have funds, have different priorities, and then the social support. So almost the end, this is a quote I like from Barack Obama, whereby they say change will not come if we wait for some other person or some other time. We are the ones we've been waiting for. We are the change that we seek. And actually, we know we are the ones to do it. And we should not wait for other people to do it. And it always seems impossible until it is done. So we know it because we've done it. And it worked. In fact, we went to 76 facilities, interacted with over 2,000 healthcare providers, and did a lot of things, a lot of data, and it was done. And we were able to generate a technical report. Thank you very much. I come to the end of my presentation.
Thank you so much, both Professor Pernan and Professor Constance for the insightful presentation. We will now open the floor for questions from our audience. If you have questions, please use the raise hand feature or type your question into the chat. I will address as many questions as possible within our allotted time. Let's start. If there is any question. You can unmute yourself and ask your questions.
Yes, thank you so much. I'm
Ronald.
Ronald. I'm
From
Ronald
South
Gikoni.
Africa.
Pardon?
I said Ronald from South Africa.
No. I'm from Makerere University.
Makerere
Uganda.
University? Oh, okay.
Yeah, Makerere University, Uganda. Thank you, Prof. Benard and Prof. Constance for the presentation. It's wonderful. My background is immunology and clinical microbiology. I work with Makerere University Biomedical Research Center. My question is it's regarding how the scalability of this project, because is it only 0 to Kenya? Is it also you have East Africa? Have you included the East African countries like Tanzania, Uganda, Rwanda to give a bigger picture? I don't know. Or it is typically a Kenyan project? Thank you.
Thank you.
I can respond. Yeah, thank you very much,
Yes.
Ronald, for that question. One thing is charity begins at home. So as we are Kenyans, we have looked at our country and we would like it to be done, but we know this can be extrapolated. There's a lot going on when it comes to sickle cell disease in terms of management, all over the country, all over the world, not the country. But for us, we decided to go to the basics, go back to the ground. We have Professor Sorre, who is an anthropologist, cultural. Back to the basics. These patients, where are they? We don't have even a registry of these patients. We don't know how many there are, access to care and the rest. So we decided to go back to the ground and see and organize the ground before we go for those sophisticated things. In fact, we keep asking ourselves or telling ourselves, if only 30% of the 5 counties are able to access and afford hydroxyurea. In fact, there's a postgraduate student who I supervise in another neighboring county in Nyanza, who found almost 30%, 29.7% of the patients she interacted with were able to access and afford hydroxyurea. If these patients are not getting the basics, then we need to sort out before we go to the sophisticated things. And then also linkage to care is what is being talked about. But now you look around, there's nothing on the ground for these babies to be linked to. So we need to sort out those basics. That's called the comment I have. I don't know whether Professor Sorre has something to say, but this can be extrapolated.
When we started our project, one of the biggest questions was, we were like armchair researchers. We were saying the sickle cell, and everybody's asking you, how many cases do we have? So there was totally nothing we could hold on in terms of data. And that is why we say, let's start. And then we started with 5 counties, hotspot counties, which are neighboring Uganda, because Busia, Bungoma, they are neighboring Uganda. And then from that time to now, we have already done almost 9 counties, because we have done Homa Bay, Kisii, we have been to Taita, we have been to part of Kisumu. So it is growing. Then from there, we can now come to Uganda. You see, you can't come to Uganda without anything. We are scholars. In fact, us, we are scholars. We don't have a lot of money, but we said we have the knowledge. Let others then fund. So what we are doing, as we are giving knowledge, then organizations like Sickle Cell Federation pick our knowledge and use it to offer service. Ministry of Health doesn't have the expertise. We give the tools, and then they use our tools to help the patients. And this is now what we are doing. We are just strengthening what is happening. The counties are there with hospitals without information. So we go there and give information voluntarily, using our own vehicles. Nobody sponsors us. Just like that. Sometimes the department can sponsor you once in a while. So we have been doing this work as scholars, as people who are just interested in making sure that we change the life within our community. Thank you.
Thank you so much. Is there any other questions?
But just before I finish on that, there is a conference coming very soon in Kenya for the first time on sickle cell conference coming by Sickle Cell Federation of Kenya. Yes, very soon. It will be the first one of its kind in Africa, I think, and Uganda. Therefore, you will also be free to come and showcase whatever you have. We look at gaps and areas of collaboration, because so far, in some places, maybe Uganda is better, like in screening of newborns. We don't know. Thank you.
Is there travel funding for those who are postgraduate students, masters and PhD students, so they can travel Nairobi to attend this conference?
Yes, yes. So long as they get sponsors, invitations, they should be able to attend.
Yes,
Even present their thesis. Like currently, I'm supervising about 6 postgraduate students doing their work on sickle cell. Different findings, access to care, social aspects, what. In fact, 3 defendants did their mock defenses recently and to do their main defenses soon. So there's a lot of interest, and there are interesting findings.
Perfect. There is a question from Maria Gerald. I don't know her country, but she thank you for your presentation and practical presentation on SD in the region. She is from Kenya, and her question: who is responsible for ensuring no duplication of activities within the counties, and how do we enforce this as practitioners?
We are not, when we go to counties, we are not going there as strangers. We work with the county health management team, and that is the ones that runs the health care systems of the counties. So we only go there to strengthen what they are doing. So we don't duplicate. So we just reinforce whatever they are doing. So we work with the ministry, we work with the SFK, which coordinates the overall quality care and so on. And through the registry, you see, we are also registering all organizations working on sickle cell conditions or disease, so that we have order. And that was the real reason, so that we coordinate. So if you say you want to work on, for example, conference, maybe in Western Kenya, we can tell you there are 7 organizations, 2 are in Kakamega, two are in Busia, and this is what they are doing. So which one do you think can help you or you can work with? Thank you.
Okay, thank you. I have specific questions for you. Let me start with the first question. What role should policymakers play in scaling up sustainable sickle cell disease control programs, and what evidence do they need most from researchers like you?
Policymakers should support research first, should encourage us to work with them and with their populations to give them evidence. Then from those evidence, we can give them evidence-based approaches to solve their problems. So the main role is to support our actions. We are not coming to take over, but if they are there, we are coming to their county, let them give us permissions. Let them, if there is facilitation, let them facilitate us. Security is needed, let us give them security so that we move around, collect data, and give to them. Then that one, they'll have evidence to work with.
My next question regarding do you see just a moment in your experience, what are the biggest misunderstandings among the public or clinician about sickle cell disease as a genetic condition?
There are two levels. There's the cultural, especially with the communities, beliefs, and then there's just the general lack of information, proper information or right information for the general population. So that is common because especially for communities, when you enter into communities, there are those beliefs, even for people who are working.
Yes.
We met a case in one of the counties where this is a son of a prominent former politician. And he said, it is this wife who has brought me this disease. And then when he left the wife and went to marry another one, again, that one also was a carrier. Again, they had a sickle. So when we went to visit them, now they are saying, we understand it is autosomal recessive. So that way you can see there's two things at the same level, belief and ignorance.
Thank you. Another important point, how can registry data be used to track treatment outcomes and evaluate the impact of new therapies such as hydroxyurea or emerging gene-based treatments?
Yeah, you can remember what I presented, whereby we had we have registries for persons living with sickle cell disease, and by registering them using the initial encounter form, we can be able to get the incidence and the prevalence of the disease. Then get other information, family information, and the rest. Then there's the return encounter form, which picks in the current information, whereby now we can be able to measure the quality of care, like accessibility, affordability, and acceptability. Then see how to intervene, and then the summary sheets to be able to see how many new and the rest, and questions asking what can be done. Probably if you go through the forms, I was a bit faster, you can be able to understand. Then when it comes to the hemoglobin variant forms, is to build the registry, people to know their sickle cell status, such that now once they know, once they are aware they carry the gene, they can make informed choices using the information we have. And that when they make informed choices, we can be able to dilute the gene and get fewer and fewer cases with sickle cell. I don't know whether I've answered your question. Prof, you can assist, clarify a few things.
Yes, I can say each of the data we collect is supported by a tool. And those tools are instruments of measuring care at various levels, either primary, secondary, or tertiary. And therefore, you are able to track the care using evidence of that score in the tool. So even if it's drugs, if it's admissions, if it is a location where it's coming from, the hemoglobin variant, you are able to track using those tools. So it is true. We can locate, track, and even provide recommendations after each of the observations.
Thank you so much. My last question for you: do you foresee opportunities for harmonizing sickle cell disease registries across East Africa to enable regional surveillance and genetic epidemiology?
That is
Yes,
our goal. That is our goal that we are, when she was explaining what some of the first 3 slides that she presented, she said, we don't know the numbers. And you see, that's the biggest question. We don't know the numbers. The numbers are there, but scattered, and not standardized. So what we started with is to come up with a tool in Kenya that can help us collect data. And now we have accepted through the ministry to standardize the tool. So you are collecting the same kind of information. We have then come up with an app where we can register our registries online for all people living sickle cell, all organization, hemoglobin variant, and so on. So if that is working, then it becomes a model for Tanzania, for maybe East Africa and other countries. But we cannot go out there with nothing in the hands.
Thank you so much.
Yeah, so it's like a basic one, but other countries can adopt and modify the information they want to pick using it as a template.
So they
it's
will
possible.
not use the same template. They should modify. You mean this?
Yeah, it depends now. There are a few changes here and there, but there's the information that may be universal.
Yes.
And then some information which can be modified to suit their situations.
Yes. Thank you again, Professor Benard and Professor Constance, for answering the questions and for your excellent presentation. It was a pleasure to have you with us. And thank you all for attending. We hope you found it informative and enjoyable. Have a great day. Thanks so much.
Yeah,
Thank you.
Thank you very much.
Thank you
Thank
for
you.
giving us the platform too.
Yes, thank you so much.